review kind of the changes with PalliaHealth and kind of what we're doing during the pandemic. So I'll turn it over to Dr. Marty to start our presentation.
Sorry about the false start. How many times have we all done that in the past 2 months? Okay, so can someone just confirm that you can hear me and you can see the presentation I'm sharing?
Yep, good on both accounts.
Okay, all right, thanks Kelly for that introduction. We thought we'd take this opportunity in the era of Zoom to reach out to as many of you as possible and offer to some an introduction to our service, PalliaHealth, our palliative care service at Agrace, and to others reintroduction, talking a little bit about changes in recent months. So the structure for our 30 minutes or so here, I'm going to share a short presentation, and Kelly's going to share a short case study. And then we'll leave hopefully at least half the time for conversation, feedback, questions, any comments. So I don't want to assume anything. So just to introduce palliative care itself. So palliative care is specialized medical care for people living with any type of serious illness. The care is focused on relief of symptoms and stress, and the goal is to improve quality of life for both the patient and the family. Palliative care teams generally work with the patient's other healthcare providers and caregivers to provide an extra layer of support. And palliative care is based on a person's needs as opposed to a prognosis or a certain disease. And it can be provided along with more traditional disease-focused, curative, life-prolonging treatment. So who are we in PalliaHealth? We have 9 nurse practitioners. We have 2 physicians, myself and Dr. Browse. Dr. Browse is a psychiatrist. We have a couple office-based nurses. We have 1 social worker, and we have a clinical assistant. The service that we're providing is a community-based consultative service, palliative care specialty service, to provide consultation to you, your patients and their families. And our model is that we're providing, we're basically doing 2 main things. We're providing recommendations for management of specific issues related to serious illness. And often that's a refractory symptom or other disease burden that is not improving despite routine treatment. The second thing that we're often providing at the same time is meeting and conversation and discussion with patients and their families or their caregivers. And that starts with listening and learning and providing then education where needed to get everyone on the same page about the medical situation. And what follows is a discussion of care goals and preferences and a review of the current care plan and the advanced care plan to try to apply those care goals and preferences to the plan. And we do help coordinate care around these issues, though we don't offer ongoing case management. So we provide initial consultation and follow-up, and our goal is to follow for as long as needed to address the issue. And our estimate is that that's probably somewhere between 6 and 12 months on average. So usually not just 1 visit, but certainly not following indefinitely. We also have access to social worker and spiritual counselor, and we meet as an interdisciplinary team once a month for each patient on service. So one question I know often on folks' mind is, trying to sort out the difference between palliative care and hospice. So hospice care is really a structured insurance benefit for a certain kind of palliative care at a certain point in life. And so many of you know that hospice care is for patients with a terminal illness expected to live only 6 months. And that involved in the decision is a decision to discontinue curative, life-prolonging type treatments. There's some wiggle room there for some disease treatments, of course. In hospice care, the hospice team takes over management from enrollment until the time of death or until the patient leaves hospice for another reason. And hospice is able to provide very robust services because of the way it is reimbursed. Palliative care is sort of the broader umbrella, and it's not generally yet a structured insurance benefit. It's really just like patients are going to see an interdisciplinary specialty clinic, except ours is sort of on wheels as a community-based service. So patients do need to have a serious illness, and usually that's impacting their daily life and function. Patients can continue to pursue whatever type of curative or life-prolonging treatment is indicated or they desire. And our service is a consultative service, and we're providing recommendations on specific issues for a limited period of time, as opposed to assuming primary care or taking over management of those issues. I think sometimes it's hard for people to know kind of when to go ahead and make the decision to refer to palliative care. So I think two main reasons to refer to palliative care to keep on top of mind. So your patient with a serious illness that's impacting their daily life, and they're having symptoms of the illness that are not improving despite your efforts and perhaps specialist efforts at providing that typical disease treatment. The other category to keep in mind is when patients and families are really struggling with navigating decisions about their current care or about making plans for their future care. And also when it can be sometimes nebulous. And so if you just have a sense that the burdens placed upon them by serious illness are accumulating, there's probably a palliative care need in there somewhere, and would encourage you to go ahead and make a referral. One of the barriers I know is it can be difficult to introduce this topic. I think the key points here are to emphasize that you're not giving up or abandoning the patient, and to be honest where you need to be honest about your concerns, about the reason. A lot of patients and families don't know exactly what palliative care is, but they know they're probably not being referred to palliative care because things are going well. So one way to balance that out and to help people digest this, I just have, 3 sort of phrases here that you can take pieces of as appropriate. So the first, while we continue to treat the disease, I want to make sure we're doing everything possible to get relief for you from symptoms or address your quality of life. Another way to emphasize that the care is going to be based on the individual and the family and not on some external priority is to reflect back to the patient and family that you want to make sure that we're doing everything possible to address the goals and the priorities that you've been discussing with them already, so they know that it's really based on their needs. Another thing that I've often used to introduce palliative care is to remind patients that we want to make sure that their plan of care is not just based on the textbook, not just based on their medical problem, but that it's informed by their values and their preferences, and that can highlight to them the need to consider their values and their goals and their priorities. So sometimes before you're making a referral, you do really have to share some difficult news. And I'd ask that you do try to do that. When a patient, if you're able to share with them that you are concerned that perhaps things aren't going as well as we'd hope, they may much better understand, for example, why it would be important to address symptom control, or why it would be important to take a step back, look at the big picture, and consider, their values and their preferences. Without that information, there's often not an anchor. It can not make much sense to them, and it can make the consultation less effective from our perspective if we're telling them one thing and they're not hearing it from other people. So once you've gotten through the hard part of sharing that information and deciding with your patient together to make a referral, how to do it. So your EHR may have an order. You may have to specifically select which service you're wanting to refer to. So you may have to write in the comment if you're wanting to refer to our sort of home-based community service at Agrace. Otherwise, staff can call this number here. They can send an email or send a fax. As much as you're able, please include any detail about the specific issue you'd like addressed. And if you have had some discussion, please do share a summary of sort of where you've gotten with discussion, and if you hit a barrier with patients and families, kind of where it stopped, so we can pick up and go from there. After a referral, we do have eligibility criteria to make sure that it's appropriate for us to see the patient for a consult. The vast majority of our cases are quite appropriate. If the case is found not eligible, we will contact you. If the referral is not directly from you, we will contact you and we'll talk to insurance, and then we'll proceed with scheduling. One of the silver linings that many of us are experiencing with COVID is relaxation of regulations and waivers around telehealth. So we have been successfully using Zoom. Patients and families do not need to download an application. They just need to be able to click a link within an email. They do need to use high-speed internet or 4G LTE cellular data, so sometimes that can be a barrier. But we've been using it successfully, even with patients who are impaired functionally or cognitively. We've seen patients in facilities, for example, and staff have brought them a laptop and tablet and helped them navigate it. Any details about that technology are covered when we're discussing scheduling. And I think now Kelly has a case to share. I know that some of these points are become much more clear and full of life when a story is shared. So Kelly, if you want to.
Sure. The case that really came to mind that was a really good example of kind of what we do as far as symptom management and just integration with the team. This was a fairly complex lady who was in her 60s who had Sjogren's syndrome with interstitial lung disease. And this poor lady had been in and out of hospitals. I mean, her first pneumonia was when she was an infant and had frequent pneumonias ever since, had been intubated many, many, many times, but also had many other medical issues as well. The highlights of her problem list were, she's got hypertension, GERD, depression. I think she had 6 or 7 back surgeries, and the last one really significantly failed. And I saw her right as she was starting the workup for Sjogren's syndrome with rheumatology. And prior to that, at the same time, she had also attempted to have a neurotransmitter stimulator placed to help with her pain. And this ultimately got massively infected. And then she was on IV antibiotics for weeks and under care from ID. And so she was in and out of clinics. It was really hard for her to even talk about goals of care. So her primary care provider asked us to come in and just kind of talk through everything with her and just kind of get a sense of what her goals were. And with her, her pain had been a chronic issue her whole life. And when I went out there to talk to her, she was on extended release morphine and immediate release oxycodone because that was the only thing that really seemed to work for her. She had had many regimens throughout her life, and they were in the process of weaning down, and functionally she was just failing as she was having this infection and doing all of these other treatments. Everything in her life was kind of shifting. So when I went in to see her, we really talked about goals of care and really looked at symptom management. A lot of her pain really seemed to be neuropathic. And she had tried both GABA and Lyrica in the past and had failed those. And her pain really seemed to do okay on the ER morphine, but really she seemed to have some breakthrough pain through the ER doses. And at one point she was on it 3 times a day, which seemed to work better. So one thing that I discussed with her was using methadone, because I thought that that would help us from a longer acting pain standpoint, as well as help some of the neuropathic pain. And it was really a great partnership with her PCP in the clinic, where we really talked about, what that would look like. The clinic didn't have much experience with methadone, so we provided lots of education and resources on what we would need to do, ordering the EKG, and really looking and troubleshooting that. And we were able to start that and actually wean down her other narcotics. And it was one of those cases where she responded fantastically well to the methadone, to the point that we were able to get off of the IR oxycodone because the methadone, and we weaned off of the ER morphine as well. And she was primarily maintained. We still had a few IR oxy available, but she really, her use became pretty limited because of that. And as I met with her controlling her pain, she also was hospitalized, I think twice in the period of 3 months because she to wean her. The second time she was intubated for 4 days. And so I actually did a joint visit with her primary care provider where we were all at the table to talk about what our concerns were, that, the next time we've kind of been doubling the length of time it takes to get you off the ventilator. The next time it could be 8 days. What are we going to be looking at? How are things going to change with you in that period? And it was just such a great conversation to have the whole team at the table to really have those discussions. And we were able to really piece apart really good goals of care. She really did not want to be a DNR because she had been intubated multiple times through her life, and that's what had saved her. She really wanted to be there. She was having a grandchild that was being born, and she really wanted to live to see that grandchild. And so we really talked about and she was very clear that if she was intubated more than she didn't want it, wean, and that was her guidance. And we actually got her stabilized between doses of prednisone, her methadone. She was able to go out to New Jersey to see her family, to meet the grandchild, to have this great trip. And then shortly after that, she came back, was hospitalized again, intubated, and this time really was not looking well. I think she got to day 7 of being intubated, and her husband is like, nope, we had these conversations. I know that things aren't going to be the same, and this is not what she wanted after we had our big goals of care. So they did wean, and she passed away in the hospital. But it was circling back. I touched base with her husband and the primary care provider after that, and it was just one of those really great, this is exactly how she wanted it to go, and we all had very clear communication, and her symptoms were as best managed as we could get them with everything that was going on with her body. So I just think that's a great story that kind of shows how working together as a team, keeping the primary care involved, because they are the ones that have carried and gotten us to this point. And many patients are very attached to everybody in the primary care world, and they want us to augment that and to be part of that team. And so this was a great example of that.
Thanks for sharing, Kelly. I was just thinking, how much of a burden you helped lift from the husband, who was, because of your conversation, he was sort of armed with that information to help him know what her decision would be.
Yeah.
And I'm sure that helped the ICU team as well. So that's the end of our formal presentation, and certainly eager for any questions or feedback.
Just in case anybody doesn't know, I muted everyone too, most everyone. So,
So if anyone has any questions, make sure to unmute themselves.
yeah.
Yeah, I have a question. I've got a patient. How do you approach a patient who's already we approached palliative care with them and distinguish that it is not hospice, because we know that they are not open to hospice, but then they've already said no, they are absolutely not interested. How would you approach that patient if we were to refer it?
I think one way is to sort of take a big step back and ask for them to come in to meet with you, just to review, where they're at and what their understanding of the situation is, and really try to make it as clear as possible that you don't have an agenda, and that you want to hear from them about their expectations for the future, about things that they hope will happen, things that they're concerned will happen. If they're willing, what their fears are around what does palliative care mean to them? Does that have a connotation for them?
Okay. All right. Just let them be more expressive about how they see the future playing out, I guess. Okay, thank you.
Yeah, I think a visit specifically, if you can, a little bit of protected time in a visit specifically for them to share, and for not to be doing any other preventive care or chronic disease issues.
Okay. All right, thank you.
Thanks for the question.
I'm going to exit now. Thank you for it was very, very informative.
Thank you.
You're welcome.
Well, if there aren't any other questions, I think we can wrap things up. Typically, Dr. Marty, I and Ben have all kind of stayed on the line for a little bit in case there's any single questions that come up. So we'll end the formal presentation, but we'll stick around for a bit if there's anything. You can always type it in the chat bar too if there's something that you don't want to verbalize. So we'll stick around and watch for those. But thanks everybody for coming today and listening to our presentation.
Thank you all.
And feel free to email me if a question comes up afterwards.
Thank you.